I'm going to, of course, focus here in the next 20 minutes or so on the real-world experience and the data around the use of Acalabrutinib for patients in the frontline or for treatment-naive CLL. My understanding is, although Dr. Sanjeev might have said that it's not available in India, my understanding was that maybe Acalabrutinib is now recently approved there for CLL and mantle cell lymphoma. Regardless if it's not, of course, it will be soon. I will just touch on an introduction to CLL. I didn't really understand completely, unfortunately, that was part of the whole program, so I won't belabor that. But I will talk about therapy in CLL, in particular, the use of Acalabrutinib and some of these other approaches, but again, a focus on Acalabrutinib. And remember, of course, as we discuss this is a disease, especially, of course, in the United States, of people who are a bit older, so the median age of diagnosis is around 70. And this is actually, in the United States, not uncommon. We diagnose about 20,000 cases every year in the United States, but the prevalence, people living with the disease in the United States, is quite high, and certainly as well around the world. And this disease affects people who are men more than women for reasons we don't understand. And the pathogenesis and biology around CLL has already been discussed. Dr. Hari did a really nice job of really pointing out that not all CLL is created equal. There are, of course, two major subsets, and those are the immunoglobulin heavy chain gene mutated or unmutated CLL. And I like to think about this as those cells that have undergone somatic hypermutation, the VDJ rearrangements that happen leading to a vast repertoire of immunoglobulin proteins that are developed. That happens in a more mature cell. And when CLL happens in that cell that's already undergone that mutational process, then it's actually more favorable. So I always think that it's good to be a mutant, and it's less good to be unmutated. And I recognize that in India, there's not profound or widespread testing of IGHV mutational status, and I hope that in the relative near future that might be valuable, however, and actually feasible. However, I will also point out that the evolution of therapy is really coming about, suggesting that we can overcome these high-risk genetic features, and it may not be as important for us to test for them given the novel targeted therapies we have, like Acalabrutinib. This is the reason we talk about the mutational status, of course, is because IGHV mutation impacts prognosis. And you can see the top curve there are those who have mutated disease. They have, again, a more mature CLL cell where the disease has developed. They do better than those people with unmutated disease. And we also recognize that there are some people with very high-risk features. You're all well aware of 17p deletions, TP53 aberrations, 11q deletions that portend to a much more difficult prognosis. We do have many unmet needs still in CLL, and especially, of course, I think in India, as was just pointed out by Dr. Sanjeev. Really, I'll focus on the front line, but understand that even in the front line, we don't cure people with standard therapies. So we do recognize that in this elderly patient population who may not be really fit for intensive therapies often, we need to provide the best therapy we can that is the most tolerable that we can. And that's, of course, why in that last presentation you saw that and discussed that chlorambucil and prednisone is still a reasonable regimen for those patients with comorbidities in the front line. However, we can improve on that. I hope we will in India by providing more advanced, better therapies that are better tolerated, and we'll focus on that data here. So a little bit about frontline therapy. I won't tell you all of this. Of course, again, that CLL-10 trial of randomization of FCR versus BR that showed, again, as you heard, improvements in progression-free survival for those people who got FCR over BR. However, there was no difference in overall survival, and the toxicity of the regimen was quite difficult, with FCR suggesting that BR is probably a more appropriate regimen in the majority of patients in India, and that's the data that Dr. Sanjeev just did reiterate that BR is the most common regimen there. What about, though, for people that can't even tolerate BR? Well, certainly we know that from the German CLL study group, the use of chlorambucil with obinutuzumab or Gazyva has been an advance. But again, that's not a cheap regimen because of the second generation glycosylated type 2 antibody, Gazyva, again, obinutuzumab. But nonetheless, in that trial, randomization between chlorambucil and Gazyva versus rituximab and chlorambucil, there was an improvement in progression-free survival as shown here for those patients who got Gazyva and chlorambucil over rituximab and chlorambucil. Still in India, of course, that the antibody therapies are probably not largely used, but suggests that chlorambucil as a backbone is in the right patients who are older, perhaps less fit, not unreasonable. I won't say a lot about BCL2 inhibitor and venetoclax for the sake of time, and then also because it was already discussed in the CLL14 trial using venetoclax and obinutuzumab compared to chlorambucil and obinutuzumab. Just remember, of course, that this is time-limited therapy. It's 1 year of treatment, and the idea is to stop therapy at 1 year. And you can see when you do that, as you saw in the prior presentations, that there was a significant improvement of obinutuzumab over chlorambucil and obinutuzumab, perhaps over more than a 20% improvement in the estimated 24-month progression-free survival. I will now, however, focus on frontline therapy with BTK inhibitors. And again, I apologize for some redundancy in the information, but do know that ibrutinib has been a game changer around the world as a targeted BTK inhibitor for patients, not only in relapse setting, but definitely in the front line. The RESONATE-2 trial compared ibrutinib to chlorambucil and showed not only a progression-free survival advantage, but actually an overall survival advantage to single-agent chlorambucil. And that really led to its widespread approval. It, however, is not without some difficulty. And I recognize that ibrutinib is not widely used in ibrutinib, but know that there are lots of adverse events and problems with ibrutinib. In my opinion, it's actually, in many patients, very difficult to deliver because of the adverse event profile. We recognize that ibrutinib can cause significant hypertension in about 15% of patients. Atrial fibrillation is a major concern. It's up to 15% as well in real-world analyses. And major hemorrhage because of off-target interactions of the drug ibrutinib with another tyrosine kinase, TEC kinase, which is in platelets, leads to platelet dysfunction, leads to severe bleeding in about 4 to 5% of patients. So we need to do better in these patients. We know that people can stay on therapy for a long period of time, but unfortunately, many people don't get to the long period of time with ibrutinib because of the need to actually discontinue therapy due to an adverse event. If you look at real-world data, about a quarter of patients will come off of ibrutinib because of an adverse event. We do know that we can improve on outcomes by adding an anti-CD20 antibody in the front line. We believe that maybe the addition of obinutuzumab to ibrutinib might be an advance, but it's certainly not clear if it's an advance over single-agent ibrutinib based on this trial that Carol Marino has now published called the Illuminate trial, comparing ibrutinib and obinutuzumab to chlorambucil and obinutuzumab, and you can see progression-free survival is better in all of those patients. We've already discussed the Alliance trial, and I again apologize, but do want to remind you that the use of ibrutinib is, if possible, improvement in progression-free survival compared to bendamustine or rituximab. But my point is to stress that ibrutinib is not really without side effects. Even though it's an oral agent, you can deliver it easily in that setting. We do recognize that there are a lot of non-hematologic adverse events. In fact, more in the ibrutinib arms than there are in the bendamustine or rituximab arm in the Alliance randomized trial. And for reasons we don't completely understand, there were actually 11 total unwitnessed or unexplained deaths in the people that got either ibrutinib or ibrutinib and rituximab. And that's concerning in a frontline patient population we're trying to deliver palliation. I'm going to just remind everyone that in the real world setting, Adverse events due to ibrutinib, as I've said, are a problem, and it's really a problem when we consider the patient population. This is a population that's a bit older, and they have adverse events of comorbidities in about half of patients that are very serious. Those are cardiovascular comorbidities or renal comorbidities, chronic renal insufficiency. So we need to do better, and that leads us to the idea of acalabrutinib. I hope acalabrutinib will be able to be used significantly in India at some point, and I'll tell you why. It's a cleaner kinase. It's different than ibrutinib in that way. You can see in the kinome maps there in the bottom left of this slide that there are fewer red dots on the acalabrutinib map than there are on the ibrutinib map. Those red dots, as you know, really are the other kinases, the off-target kinases that each drug interacts with. Of course, the primary selected target is BTK for both of these agents, but there are many more off-target kinases that ibrutinib interacts with and acalabrutinib. There's more than 40 that ibrutinib interacts with, where there's only about 7 or so with acalabrutinib. And that's why we believe this might be a major advance for patients. We believe that we see less adverse events with acalabrutinib because there are less of those off-target kinases that are interacted with this second generation agent. And that's kind of further shown in the table to the right. You can see that, of course, acalabrutinib has very little interaction with many of these kinases compared to ibrutinib, looking at the IC50 levels. As an example, acalabrutinib does not interact with EGFR, but it does, and that's very different than ibrutinib. And that's why we see more diarrhea and rashes, most likely with ibrutinib than we do with acalabrutinib. And I alluded to the one up close to the top, TEC kinase. Ibrutinib does interact with TEC, and acalabrutinib really does much less. And that's why we might see more major hemorrhage with ibrutinib than we do with acalabrutinib. Again, TEC kinase is in platelets. It leads to platelet disruption and the inability of platelets to aggregate to collagen, and why, again, we believe that there's more bleeding potentially with ibrutinib than with acalabrutinib. So here's the important data to know, and this was alluded to by Dr. Harry a minute ago, but we know the Elevate-TN trial was a randomized trial in frontline newly diagnosed CLL patients who are a bit older. You were either over the age of 65, or if you were under the age of 65, you had to have comorbidities, and you were randomized to either get acalabrutinib with or without obinutuzumab, and the comparator was chlorambucil and obinutuzumab, and was shown that there was a dramatic improvement in the primary endpoint of progression-free survival with acalabrutinib, either with or without the obinutuzumab compared to the chlorambucil obinutuzumab. In fact, there was at least an 80% reduction in the risk of relapse, progression, or death with acalabrutinib as a monotherapy, an oral monotherapy compared to chlorambucil obinutuzumab. And it was, in fact, a little bit better with obinutuzumab in combination with the acalabrutinib. That's actually a 90% reduction in the risk of relapse, progression, or death. However, again, that does not necessarily mean that the anti-CD20 antibody is required for therapy. And based on this data in the United States, both monotherapy acalabrutinib and therapy of acalabrutinib with obinutuzumab are approved for frontline use of treatment. And that holds true for all the subtypes of patients. You can see here that there are even people who are older, people who have advanced stage disease, those patients with bulky disease, 17p deletions, 11 Qs, complex karyotypes, IVHG mutations. The forest plot all favors the use of acalabrutinib or acalabrutinib with Gazyva compared to the chlorambucil Gazyva arm. There was, in fact, an equal opportunity to have improvements in progression-free survival, regardless of what your high-risk features were. So very important that this was appropriate, not just for patients with standard or even favorable risk, but even those patients with more high-risk disease. And here's where I think we have a major advance. I think it's really in the adverse event profile. You can see that there are relatively low rates of non-hematologic grade 3-4 adverse events with the acalabrutinib monotherapy arm, or even with the addition of Gazyva. Low rates of those kind of GI toxicities. It's very well tolerated. You don't see significant rashes, again, perhaps because you might not target EGFR. And one of the things that's interesting and unique to acalabrutinib is that you can see a headache. It's usually early. You can see it's grade 1, grade 2. It's self-limited in the vast majority, rarely ever significant. It's highly responsive to caffeine. And so coffee or Coca-Cola or something like that would certainly help. And usually it's mild and goes away if people do have it. What's important to note is that the discontinuations of acalabrutinib are relatively uncommon. In fact, most people will be able to stay on therapy for long periods of time, and I'll show you some of that data here in just a second. So about 10% of patients have to discontinue therapy due to acalabrutinib, and that was actually less than what was seen with the chlorambucil and obinutuzumab in the Frontline study. And if you look a little longer term, more than 2 years, almost 8 out of 10 patients are remaining on acalabrutinib-containing arms, doing well at tolerating therapy. I do want to remind people that, again, this is important for patients if we can deliver it to them, and that it will be really well tolerated, and it will be something that can provide a benefit to an older patient population with advanced comorbidities. We do have long-term data as well in the frontline setting from our phase 2 study that I want to briefly show you and then wrap up. The acalabrutinib has been looked at as a monotherapy in our upfront 001 trial that we performed, and now we have more than 4-year follow-up data using this monotherapy for CLL in the frontline. These were the patients that were in the frontline trial. These were frontline treatment-naive patients who needed therapy, and you can see the key inclusion-exclusion criteria there, but they would be as you would expect from a frontline trial. The trial did allow for patients with high-risk disease. There were 99 patients in this trial. The median age was 64, but you can see the oldest patient treated was 85. So this is a therapy that we like for older people where they can tolerate the treatment. Of course, advanced stage was not uncommon, and down at the bottom you can see the genomic risk of 11 Qs, 17 Ps, and TP53 aberrations in a select number of patients. In these 99 patients, the response rates were outstanding due to single-agent acalabrutinib. Almost 100% response rate, and as you would expect, the vast majority of those are partial remissions, but those are very durable and valuable for patients. And that's shown here now with more than 4-year follow-up, looking at not just at progression-free survival, but event-free survival. So this is important, and that it really takes into account as well treatment discontinuations due to an adverse event. And you can see all the way out here, more than 4 years, we're well over, we're at least 90% event-free survival. So people alive, taking therapy without progression and without intolerance, obviously important. And if you look at the long term, very important, we see that the drug appears to be well tolerated. We do see that headache that we've mentioned, but again, it's usually grade 1, grade 2, and it's self-limited. We have low rates of arthralgias, relatively low rates of GI toxicity. Hypertension in this trial of all grades was around 20%. That's not maybe dramatically different from ibrutinib in this trial, but we know in other trials it appears to be less. We do also believe that this is an advance over ibrutinib because of the potential for less atrial fibrillation. If you look at long-term in these patients, it's about 5% atrial fibrillation. In the real world with ibrutinib, it's around 15%. That's very different and very important for these patients. And also know that with ibrutinib, albeit very rare, fortunately, you can see ventricular tachycardias that we haven't really seen with acalabrutinib, but it's not to say that, of course, it couldn't happen. It does appear, though, from a cardiac standpoint, this is a safer drug. And major hemorrhage. Major hemorrhage is about 4%, as you see with acalabrutinib. It's on the order of 8 to 10% with ibrutinib in multiple studies. We still recognize some risk for hypertension as well, and of course there are other associated events of clinical interest, but again, a well-tolerated therapy. And if you actually look in those 100 patients, how many had to discontinue therapy due to an adverse event? Only 6 of the 99 patients actually had to discontinue therapy due to an adverse event. So 86% of patients more than 4 years out on treatment are maintaining on therapy with the single agent acalabrutinib. So I'm sorry I've gone a little over time, and I apologize to everyone, but I'll remind you that this is an important advance that even in India, when you can deliver it to your patients. I do recognize that the vast majority of the pay comes from self-pay and very little with reimbursement. Nonetheless, it's a very important, highly efficacious regimen that provides long-term event-free survival, very well tolerated with low rates of discontinuation. And we're certainly excited about using it here as our frontline therapy in the United States, and we'll see how that evolves in India over time. In the United States, it's approved both with or without obinutuzumab. And I think in the interest of time, I'll just skip this case study and remind you that we still have opportunities for improvement. I note the patients are not being cured with these therapies, and I think we'll be excited to see about new advances in therapy as we move forward in the near future around the globe. Forgive me for the somewhat longer presentation. I really am honored to be with everyone here today, and I'll look forward to the chance to come and visit in person if I could someday. I've always wanted to come and visit you and the incredible work you do in a challenging situation. So thank you for having me this morning.